With Catherine Kane from the World Health Organization to discuss human resources for health. As you know, the rules of the lightning chat, it is 15 minutes. We're going to dive right in. At the 15-minute mark, we'll be asking you as participants in the room the question, do you have further questions? Do you see the need to discuss this topic further? And only if you make the decision that we should extend, then Catherine Kane, we will turn to you and ask if you accept to stay on a little bit longer so we can keep the discussion going. The principle, of course, is to enable you to determine if and how this topic of human resources for health is Catherine Kane, I'm going to ask you to introduce yourself and answer the first question, really. What is the vision for human resources for health and why is it relevant now? What are HRH challenges that are current and that actually matter, that affect immunization service delivery and performance?
Thank you, Retta. My name is Catherine Kane. I work for the WHO Health Workforce Department, and I hope that you will note my excitement in speaking to this very important audience on my absolute favorite topic. Human resources for health, what does that mean? It's health workers. So for human resources for health, our vision is improved access to health services through strengthened health workforce available and accessible to all. And this is with the ambition of improving health, social, and economic development outcomes by ensuring universal availability, accessibility, acceptability, coverage, and quality of the health workforce through adequate investments to strengthen health systems and to implement effective policies at national, regional, and global levels. In point of fact, there is no health without health workers. If there's somebody in the IA2030 course who's not here, I'd like to know how they're going to deliver immunizations without my people, without our people. So while we are facing, in our last report, we noted that we were facing a gap of about 18 million health workers. And while there have been some gains over the past 5 years in that anticipated gap in the health workforce, we're also facing multiple challenges due to COVID-19, layered on to the existing challenges of maldistribution and inavailability of health workers to meet those who are least accessible. So we're dealing with illness, death. Over 115,000 health workers are believed to have died due to COVID-19, departure from service, mental health issues, fatigue, burnout, workforce stoppages due to indecent work. There are any number of factors that are really challenging the health workforce. And just to give you an idea here, the HRH challenges, HRH is Human Resources for Health, we have conducted surveys over the course of COVID-19. And during those surveys, 3 of which have been conducted internationally up till now, we have noted that there has been, for a majority of countries that responded, in fact, the response rate was in the 70%, that one of the major impediment to delivering not only COVID-19 tools, but also essential health services is health workforce shortages. And specifically to immunization, while there was a little bit of a lower rate of reporting in the second pulse survey, the third pulse survey in Q4 of 2021, in fact, indicated a slight uptake again in which accounted for 53% of countries facing difficulties in delivering both routine immunization and outreach services. Those are really connected to health workforce availability.
Thank you. So, Catherine Kane from the World Health Organization. Of course, I turn now to the participants in the room because we have more questions to introduce the topic, but we will be turning to you, to Bernadette, to Bawani, Daniel, David, Dianaba, Fodaya, Germain, Mauricio, Milena, Musand, Oluwakemi, and Sume. So please, you can already share your questions in the chat, or you can raise your hand and we'll certainly be turning to you, asking you what your questions are about this critical topic and also what is your experience as we progress in this lightning chat. So Catherine, my next question for you is, can you tell us about the principles that govern the global strategy on human resources for health, and what does this global strategy seek to attain? What's the goal here with this HRH issue?
Global strategy is fundamental to our work, and it seeks to yield well-equipped and supported health workers in sufficient quantities to meet population health needs. That's our goal overall, writ large. So what are the principles that are governing that strategy? And there are a number of them that really speak to the work that we do daily. They are to promote the right to the enjoyment of the highest attainable standard of health. And that's agreed to by member states. It's agreed to by your countries. What are we seeking to do? It's to provide integrated, people-centered health services without stigma, without discrimination, to empower and engage communities to participate in their own health, to uphold the personal, employment, and professional rights of health workers. And those are safe and decent working environments, freedom from discrimination, coercion, and violence, and decent work. And I'll go into a bit more what decent work means to us. To eliminate gender-based violence, discrimination, and harassment. 7 in 10 health workers are women globally, and they face an increased rate of violence, discrimination, and harassment in the workplace, which has been more pronounced throughout the pandemic. We look to promote international collaboration and solidarity, aligning with national priorities, to ensure ethical recruitment practices conforming to the global code of practice on the international recruitment of health personnel, to mobilize, to sustain political and financial commitment, and to foster inclusiveness and collaboration across sectors. These are some of our guiding principles, and those are joined with promoting innovation and the use of evidence.
Thanks, Catherine. So again, I turn to the participants. Please raise your hand or type your question, comment into the chat. You can ask your question in French. If you are a French speaker, you should be. So Catherine, my next question is now to zero in on the context for Immunization Agenda 2030, and really to ask, why is it essential in that IA 2030 context to ensure the availability of a quality health workforce, and what impact, what difference does this make for immunization performance?
I'll say to begin with that I know that most of your learners will have looked at IA 2030 with great detail. So you'll have seen the areas that we laid out with regard to what's necessary to ensure about availability of a quality health workforce. But while innovative ways are being found to distribute and administer vaccines, digital support, vaccines that are delivered orally, there's one component that actually remains right there. They are delivered by whom? By health workers. So you need health workers to do your work. They are the essential component, in addition to, of course, the vaccines themselves, in ensuring that populations receive them. But I think it's important to note that often the populations that are at the greatest risk of vaccine preventable diseases and in the greatest need of vaccinations are those who are furthest from health systems, those in communities that are hard to reach, those populations that don't have a great deal of trust in the health system. And those, in fact, are where health workers are really your guiding force. Surveys show that populations trust health workers as messengers of information on health, more so than political leaders, more so perhaps than their mayor, and we hope that this continues to be the case. Those health workers have got to be present in communities. They've got to be providing regular services all the time, not just dropping in and offering COVID-19 vaccines to a population that's suffering from malaria, or to populations who have Ebola, or to populations who aren't getting their primary healthcare needs met. So in order to leverage that trust that communities have, that is absolutely necessary to get vaccines into bodies and better protect populations, you need to be cultivating health workers, leveraging the trust that they have with communities, building trust with those health workers, whether it's by ensuring that they themselves are vaccinated, or whether it's by ensuring that you address their questions, and I know that we're not using this word, but their hesitancy about receiving vaccines themselves, ensuring that they have sick leave, as a matter of fact, after they receive vaccines, so that they don't have to worry about, if I get this vaccine and have negative effects, will I have to miss a day of work and a day of pay to receive it? So work with your health workers. This is why, one of the reasons that you'll want to work with HRH to ensure the availability of a health workforce. The other element is that surveillance, presence in community, is the first harbinger of virus detection and the first element that calls out need for vaccines. IA2030 calls measles the canary in the coal mine. So let's call health workers your urologists. They are, in fact, the workers who find those canaries. They are the workers who deliver that information through surveillance, and they are the workers who deliver the vaccines. So I would say that those are probably some of the key reasons I look at for why you want to ensure the availability of a quality health workforce.
Thank you, Catherine. So I'm going to ask you one more question, because participants, learners in this WHO course on Immunization Agenda 2030 are going to be developing an action plan. So I'd like to know, can you give us a quick answer? What are the key considerations, or a few of them, the most important ones, in human resources for health planning? Someone who's putting together their IA 2030 action plan and wants to take into consideration these important issues around human resources for health, what are the top 3 considerations they should be thinking about?
Oh, Retta, trying to reduce this to 3, you're challenging me. Well, the first consideration, or the first recommendation, I'm not going to make it a consideration, is talk to your human resources for health colleagues. We are ready and waiting to engage with you so that you have a quality health workforce. So this is, and the workforce is really a reflection of your population needs. So 1, 2, and 3. 1, individual level, you want to ensure that you've got the necessary support for health workers. You identify the competencies that are required to deliver the services, that you identify and cost what your human resources for health will be. The more we rely on ad hoc volunteers, the more we invest in training and retraining, and the more we take people away from the health services that they're delivering. So ensure that at the individual level, you have workers who are educated, trained, supported through supportive supervision. Don't lose the supervision. Have the right job aids, are paid and are protected to do their work. At the management level, ensure that supervisors are appropriately trained in order to get the best out of their health workers. Ensure that you are factoring into your budget the need for the human resources for health, and that you're working with other departments, divisions, et cetera, to look at where you can maximize your investment. So often human resources for health is funded out of a variety of budgets. So for example, look for where you can streamline service delivery, whether that is through routine immunization in the health facility, or whether it's through outreach campaigns, or you could, for example, deliver a routine immunization for children, and then to their mothers who bring them, deliver COVID-19 vaccines. So really look at that integration and opportunity to leverage the trained, supervised health workers to deliver for the best. And lastly, at the political and organizational level, join us in asking for the appropriate resources for human resources for health, for looking at policies and regulations to ensure that workers are practicing at the highest level of their training and certification. And where necessary, we look for regulatory waivers, for example, for a different category of worker to deliver an intramuscular injection. In many countries, only certain health workers can deliver this. But if we can optimize tasks and roles so that a higher trained health worker is watching for signs of epi, then in fact you can use a community health worker to administer the intramuscular injection under supervision.
Great. Thank you very much, Catherine Kane from the World Health Organization, for this lightning chat about human resources for health. We have two great questions, one from Gerald Sume and the other from Bhawani Shankar Tripathi. So let's start with Gerald. Let's see if we can get you. Yes, your microphone is already unmuted. Gerald, over to you. If you are able to turn on your webcam, that is, of course, appreciated, but not required. Are you able to speak to us? Do introduce yourself. Don't forget to tell us who you are and what you do.
Thank you, brother. I'm Gerard. I work with WHO in Cairo regional office. So thank you for this opportunity. So my question is around, low wages and inadequate infrastructure are some of the main causes of brain drain from developing countries towards the developed world. And this definitely leads to significant challenges in terms of quality and quantity of the human resources left behind in these developing countries. So from your experience, I want to know what WHO is doing to address this. You talked about needs, cost. This definitely entails some resources which most of these developing countries don't usually allocate to their healthcare system. So we have these situations where you can see the doctors to the ratio of doctors to the population, or even nurses to the population, is very, very far from what is recommended. So what is WHO doing to address this drift in the little or the skilled human resources that we have in these developing countries because of these low wages and infrastructure?
Thanks, Gerald. Your question is clear. Over to Catherine Kane from WHO.
Sumit, that is a really beautiful question, and I will pass through the Learning Foundation some additional resources to talk to this question. But in its base, human resources for health is not just health. It's labor, it's education, it's finance, it's equity. So we work with all of those sectors on these issues that you're identifying. And we start with what's called a health labor market analysis so that wages for health workers are set at similar points. When we work with countries, we recommend that wages for a health worker delivering XYZ services are similar to those of a worker in another sector delivering based on a similar level of expertise. So that requires making investments and making allocations in the health budget and in the finance budgets. And what's important within here to remember is that when you invest in a health worker, you're not just investing in one person's salary, you're actually investing in something that has social and economic and gender equities. When you invest in a health worker, for example, I work frequently with community health workers. When you pay them, they're women, increases equity, increases job opportunities, increases the case for education in the community. And most women who are paid community health workers are going to reinvest in their neighbor who's selling fruit. They're going to reinvest in ensuring that their parents have elder care, whether that's by themselves or by their neighbors. So there are multiple investments that you get when you invest in a health worker. We are trying to bring that to countries. Then when you talk about the brain drain, we need to create opportunities for health workers to advance throughout the system. And this involves looking forward and not just saying, we're going to have a health worker, they're going to do the polio campaign, and then we're done. And then when we have another polio campaign, we'll grab workers from the community again, retrain them, and send them out. It's actually investing in the long-term view of health workers where we train them, and then you could have a community health worker who becomes an associate nurse midwife and who moves her way up. And when you create career opportunities and give people opportunities within the community, you keep them in their country. Similarly, on the macro level, we are working with receiving countries as well as with departure countries to put into practice the global code of conduct in human resources for health that governs migration and ethical conduct of countries, for example, who may be receiving countries. Similarly, invest in the education, whether it's within the country or whether it's through exchange programs where a doctor from a lower income country may go to learn new techniques in a higher income country, but then that doctor is expected to return to its receiving country. But by creating decent work, by ensuring protection, we in fact create the grounds for health workers to remain in their own countries and to leverage their considerable cultural expertise and to return to the country that investment.
Thanks, Catherine. So our next question is from Bhavani Shankar Tripathi, and with a concern over fragile contexts or conflict situations. Bhavani, the floor is yours. Please state your question and also explain to us why are you interested in this question and in these issues around human resources for health in conflict situations.
Thanks, Reda. Thanks for giving me this opportunity. My name is Bhavani Shankar Tripathi. I'm from India, formerly with the UNICEF India Country Office. People who would know about India, the challenges that India faces with respect to the population density, the quality of health workers, and so on and so forth. In spite of that, India has done a tremendously good job. It has become a global example in the COVID management and vaccination program that you have seen. Within routine immunization program, it is currently at 76% as for the recent National Family Health Services survey result. So it's doing a great job on that front. However, challenges do exist, and what Reda just asked me as to why I should be specifically asking a question like this. In an ideal situation, in an ideal context, we know the kind of health workers we have, we can train them and so on and so forth. But there are pockets in India which actually are inaccessible to health workers in conflict situations within the community. For example, some of our states and districts are governed by naxalism, or naxalism is a challenge there where reaching out to these people and the communities there becomes a difficult thing for health workers. Of course, threat to life and not allowing access to those people there. And of course, the fear of the health workers wanting to go there. So there is hesitancy. How do we, and what recommendations would you have from your global experiences or WHO's global experience from other countries as to what kind of health worker or health staff policy can the state adopt in situations like that?
This is an incredibly timely question, especially as we're looking at increased situations of fragility, conflict, and violence. I spend every morning in the discussions with our strategic operations center, and we have been following very closely any number of FCV situations. One of the most important and most enduring issues within health is the protection of health workers. You can't expect them to deliver services unless they're protected, and you'll be aware of the Attain Health Workers Project, the continued calls to respect the Geneva Conventions and their 4 additional protocols. And in fact, the health workforce is currently engaged and will present at the World Health Assembly this year the Global Health and Care Workers Compact that speaks to 4 different dimensions of protection of health workers. Now, when you talk about health workers going into areas, you start with protecting them. But then you also look at how you're reaching populations and how you're reaching populations with trusted ambassadors. And if I were to speak of the India experience, I'd say one of the great investments that you have made is in your ASHAs. Those are members of communities. They are living in the communities. And so the question then is, how do you ensure that they have the connection with the health system and have the supplies that they need in order to deliver the services that they're intended to deliver? So with HR for emergencies, you have the investment that we should be continuously making in primary health care, so trusted care at community level in whichever situation. We've also got, how do you access populations in need with the services when they may be, for example, on the move? And this can include standby partners. It can also include ensuring that when populations are on the move, that those health workers among them have the resources necessary and the licensure and necessary waivers in order to deliver services within those situations. So if you look at refugee populations, sometimes they'll be in another country where the health worker the licensure won't be honored in order to deliver services. And we need to continue chipping away at that. And we need to keep chipping away at the dearth of health workers. And at the very end of this, health is a marker for peace. When people have the health services they need and the economic stability they need, we chip away at the reasons for conflict. So we have a number of recommendations specific to surge deployment, optimizing tasks and roles, which is not giving away tasks, but deciding which health worker can deliver what activity. And we've got guidance for COVID-19 on delivery within emergencies, and we're currently in an effort to define better for countries and in support of countries the public health and emergency workforce. So what competencies are needed and what should we be developing in the health workforce of tomorrow? But I'd be glad to send again through the Learning Foundation some materials that we've developed specific to how to identify surge within these conditions, and we're currently updating. But there are some key ideas on how you can surge your health workforce to address additional service needs and access needs.
Wonderful. Thank you so much, Catherine Kane from the World Health Organization, for this lightning chat. Of course, we've shared with participants in the WHO course on immunization agenda a number of key resources shared around human resources for health. Thank you, Catherine. We look forward to receiving your further questions and comments for participants in the course. You have several channels, several ways to do that. Thank you. And we do, when we can, we do recognize and thank our guests with a round of applause. Thank you, Catherine. Take care.